really, when we looked at our experience with it over 10 or 12 years, it was about 39% of the time it worked. And we had about 42% side effects of that kind of scarring. So in general, periocular chemotherapy is an adjuvant, meaning we use it to help intravenous chemotherapy. But as a standalone treatment, it's not widely used, but it can be used if needed. The next is intra-arterial chemotherapy. This is using a different type of chemotherapy that's injected directly into the ophthalmic artery. That chemotherapy allows us to get a higher dose within the eye and a theoretically lower dose systemically. The advantages is that, well, it can be used for all groups, A through D, and some of the E's. It has a little bit better control of seeds than intravenous chemotherapy. It is really good at taking care of subretinal seeds and okay at taking care of vitreous seeds, so it's good for that. We do give, in general, lower systemic doses. However, we still get lower white counts with this type of therapy, so it's still chemotherapy. The chemotherapy goes through the artery and still gets into the system, but we try to use lower doses to minimize the effect compared to intravenous. The limitations are that it requires a skilled interventional neuroradiologist or neurosurgeon that is accustomed to working with chemotherapy. And the last part of that sentence is very important because most of these people are very skilled at taking care of aneurysms and strokes and all types of neurological vascular disease, but when you give them chemotherapy, they're not aware of its toxicity. It's not like the dyes that they inject normally or the glues that they use to thrombose things, and there is a learning curve on how to do it properly and without a lot of complications because it is a higher toxicity to the medication. And so the complications with this are exceedingly higher than, say, intravenous chemotherapy, but the efficacy is also higher as well. So you can have vascular occlusion because the chemotherapy is toxic to the blood vessels in high concentrations, and you can get that in the eye. So the central retinal artery can go down and you can go blind from it. You can have choroidal vessels that don't work because of the toxicity, and that affects the vision. You can have that affect vessels in the brain. You can have a complication of a catheter put in a small femoral artery in these children. So it's also limited by the size and age of the baby because the vessels need to be big enough to do the procedure. But overall, it can cause fairly dramatic reduction in tumor size with a lot less wear and tear, so to speak. So if we look at its efficacy in the easy groups, I would say B, C, and D, or B and C, it's usually 100% successful in controlling those eyes. In D and E, it becomes a little bit less efficacious compared to, well, in general. And then if you look at a nice paper by Dr. Munier, he compared his intravenous chemotherapy use with his intra-arterial chemotherapy use over his career and found that there was about a 5 or 6 month decrease in the time that it took him to control the disease within the eye. And he had about a 40% higher salvage rate for the eyes that he used. The vision was slightly better because he compared it to eyes that were enucleated that he couldn't save, and the ocular toxicity was a little bit higher in the intra-arterial group compared to the ones with the intravenous. So overall, as you go with higher doses of chemotherapy to the eye, the local complications are higher, but the efficacy is as well. Intravenous chemotherapy is another way we deliver chemotherapy directly into the eye. And this is good for vitreous seeds. So you can see in the cartoon, if you have vitreous seeds, they can be challenging to treat with intra-arterial, with intravenous, with periocular. And so intravitreous, meaning it directly injected into the eye, can achieve higher levels of chemotherapy within the vitreous, and these is the best way that we have currently to treat these seeds. So what are the limitations? Well, as you inject higher levels in the eye, you have higher levels of toxicity. So when we looked at the ERG studies of patients that received the injections, for each injection, the ERG would go down a certain amount by every injection. So the more injections you needed, the more toxicity you would observe, at least on the retina's function. You can get retinal necrosis, you can have RPE changes. So there's higher toxicity with this mode of injections, but again, it's our best tool to get rid of these vitreous seeds, which sometimes are the reason we lose the battles and lose the eyes in eyes that can see well. So here's a baby getting an injection, and you can see there's we use a very small needle, and then we freeze it with the cryoprobe, as you can see here. And so one of the agents that we inject is fluorescent, and you can see under the blue light, you can see the medication in the syringe, and then within the eye, it's distributed within the vitreous. So you can see how that gets in there. And so eyes that have pretty dramatic vitreous seeding can actually get better. And before this use of chemotherapy this way, we really didn't have a good way to control that type of disease. Here with really diffuse seeds, you can see after one injection, there's a nice response. So if you look at the statistics on that, some of the papers, seed control can be pretty high, 83 to 100%, but also the side effects, again, are inversely related with its efficacy. You can have a significant amount of ERG toxicity as well, and there's a bunch of papers that kind of go over this in the literature. But the short story on this is that it does work well for seeds. It does have significant toxicity, and so that's kind of the price you pay to try to get rid of those. Surgery, we had a nice talk about enucleation, and enucleation is excellent because it can be used for advanced eyes or recurrent eyes, and the chance of recurrence in the eye is 0. But the limitations is loss of the eye actually precludes vision as well, and the need for prosthetics. And thank God for